Okay, good evening and welcome to the IMF Medicare 101 webinar. Thank you so much for joining us. I believe some of you are joining us via your computer and listening in, and there are others of you on the line. For those of you on the phone, we just ask that everyone please mute their lines by pressing *6. And at the end of the presentation, we will have a question and answer session where you will have the ability to unmute your lines to ask a question. For those of you joining us through your computer, we ask that you use the Q&A section on the webinar to write in your question, and we will hopefully be able to answer it at the end. I first just wanted to thank both Bio and Celgene for providing educational support to make this webinar possible, and give you some brief slides on the IMF Advocacy team. This is Megan Busby who's speaking, the Senior Director of Advocacy for the IMF. I do have my colleagues all on the line with me. They are Ray Wiesek and Taylor Patton, who are Advocacy Associates, as well as our Federal Government Affairs Consultants located in D.C., Jennifer Lieb and Joanna Gray. I also wanted to mention that this webinar is being recorded so that we will be able to post it later online. So you'll be able to find our contact information on this slide on the web, and our contact information is also listed on the IMF website under the Advocacy tab. So to become an IMF advocate, it's pretty easy. If you aren't already signed up, you can visit advocacy.myeloma.org. On the bottom right hand of your screen, there is a section called Go. Click the Go under Sign Up. There's some basic information for you to fill out, your name and address, email address, and phone number, I believe is optional. You click Register, you are then signed up to be an IMF advocate. And what that really means is that you will receive a monthly e-newsletter from the advocacy team with all of the work that we're doing, and you will also receive any pertinent, important action alerts that we would like you to send an email to your legislator on important pieces of legislation that impact the myeloma and cancer community.
You hear that?
I also wanted to mention that we do have a couple of specific Medicare resources that the IMF has created, one of which is the Multiple Myeloma Insurance Questionnaire, and that to the right is a picture of what the questionnaire looks like. It is essentially a guide for when, not just for Medicare patients, really for any of our patients who are searching for a new insurance plan. It gives you some questions that you should take into consideration when shopping around for that plan, and questions you can pose to potential insurers to make sure that you're receiving appropriate coverage. The other resource that we have is called Medicare and the Affordable Care Act. This is provisions under the Affordable Care Act that was passed into law in 2010 that apply to Medicare beneficiaries. Both of these resources can be found at healthcarereform.myeloma.org. Okay, I think that's better. Hopefully everybody can hear me still. The Medicare websites that I'd like to draw your attention to are Medicare.gov, which is the official U.S. government site for Medicare, CMS.gov, which is the Centers for Medicare and Medicaid, which oversees Medicare, and then a national nonprofit, nonpartisan organization that provides education, advocacy, and legal assistance for Medicare beneficiaries, which is MedicareAdvocacy.org. And finally, I want to welcome our special speaker this evening, Dr. Gretchen Jacobson. She is the Associate Director with the Kaiser Family Foundation's Program on Medicare Policy. I do want to note that Dr. Jacobson does not work for CMS or any government agency. Kaiser Family Foundation is a nonprofit, nonpartisan organization. Dr. Jacobson directs and conducts projects pertaining to the Medicare program and the population that it serves at Kaiser. and she previously was an analyst in healthcare financing at the Congressional Research Service, and while there directed research on the future market value of pharmaceuticals, medical devices, and health services. She holds a PhD in health economics from Johns Hopkins School of Public Health and a MS in epidemiology from the Harvard School of Public Health. At this time, I am happy to turn things over to Dr. Jacobson for the remainder of the presentation.
As Megan said, the Kaiser Family Foundation, if you don't know, we provide research and information to policymakers, the media, and the public on the Medicare program and the people it covers. Also, to make this clear, we are not at all associated with the health plan or with the Kaiser industry. We're a completely independent, nonprofit, nonpartisan foundation. So today I will provide you an overview of the Medicare program and the characteristics of the people covered by the program. The Medicare program was signed into law by President Johnson in 1965. And the original idea of the program was to help provide health and economic security to the nation's seniors. Individuals are entitled to Medicare regardless of their medical history or income. You're eligible for Medicare if you're over the age of 65 or under the age of 65 and are disabled, have end-stage renal disease, or have Lou Gehrig. Today, the Medicare program covers 54 million people, 9 million of whom are under the age of 65 and disabled. There are certain times of the year when eligible individuals should enroll in Medicare. The initial enrollment period for Medicare is during the 3 months prior and the 3 months after an individual's 65th birthday. Individuals who did not enroll during these 6 months may be required to pay penalties in the form of higher premiums depending upon their circumstances. These eligible individuals who did not enroll around their 65th birthday can enroll during the general enrollment period between January 1st and March 31st of each calendar year. For individuals with health insurance from their employer, once their employment or group health plan insurance ends, they can sign up for Medicare during the following 8 months. And then finally, there's an annual open enrollment period, and this is when individuals can change their prescription drug plan or Medicare Advantage plan. And this period occurs between October 15th and December 7th of each year. If an individual changes their plan during the annual open enrollment period, the changes go into effect January 1st of the following year. So as you can see, there are many different time points to keep in mind for Medicare enrollment. The population covered by Medicare is diverse. On the whole, many people on Medicare have relatively low incomes and relatively little in savings. Most are also in frail health. 45% of people on Medicare have 3 or more chronic conditions, and almost 1/3 have a cognitive or mental impairment. 27% of people on Medicare are in fair or poor health, and 20% are functionally impaired and unable to perform at least 2 tasks required for daily living. So as you can see, this is a population with significant healthcare needs. People on Medicare range in ages. People who are under the age of 65 and disabled comprise 17% of the population, and people ages 85 or older comprise 13% of the population. Sorry, I previously meant to say 16% of the population for the under 65 disabled. And finally, 5% of people on Medicare live in a long-term care facility, such as a nursing home. Medicare is comprised of 4 parts, which are named Parts A, B, C, and D. Parts A and B were both part of original Medicare that was signed into law in 1965. They are sometimes referred to as traditional Medicare or original Medicare or fee-for-service Medicare. Medicare Part A covers inpatient hospital care, skilled nursing facility care, and some home health services and hospice care. Part A generally does not have a premium because people are entitled to Part A after paying payroll taxes for at least 10 years. Part A does have a deductible per benefit period, and to explain this, A benefit period begins the day you go into the hospital or skilled nursing facility or other care provided by Part A, and ends when you haven't received any Part A covered services for 60 consecutive days. Medicare Part A also requires cost sharing for services. Medicare Part B covers outpatient care, such as physician services, outpatient hospital care, diagnostic procedures, and durable medical equipment. For Part B, most beneficiaries pay a premium of $104.90 per month in 2014. The premium is income related, meaning that higher income beneficiaries pay higher premiums. And Part B also has an annual deductible and requires cost sharing for most services. Parts C and D are different from original Medicare because they involve the delivery of Medicare benefits through private plans. Part C, which is also referred to as the Medicare Advantage program, allows people on Medicare to receive Parts A and B through private insurance plans, such as HMOs or PPOs, that contract with the Medicare program to provide Medicare-covered benefits. So it's a private plan version of Parts A and B. In addition to the benefits covered under Parts A and B, the Medicare Advantage plans typically offer lower cost sharing and cover extra benefits that Medicare does not cover, such as eyeglasses, gym memberships, or dental care. Most Medicare Advantage plans also provide the Part D prescription drug benefit. Enrollment in Medicare Advantage plans, as you can see here, has almost tripled since 2003, growing from 5.3 million beneficiaries in 2003 to 15.7 million in 2014. In 2014, about 1 in 3 beneficiaries are enrolled in a Medicare Advantage plan. And something to keep in mind, though, is that enrollment in these plans and what is referred to as the penetration rate varies greatly across the country. These enrollees in Medicare Advantage plans typically still have to pay the monthly Part B premium, and many also pay an additional premium for their Medicare Advantage plan. Medicare Part D is an outpatient prescription drug benefit that allows people on Medicare to receive prescription drug coverage through private insurance plans that contract with Medicare. People can enroll in either a standalone prescription drug plan or one of the Medicare Advantage plans that includes Part D benefits. Under Part D, beneficiaries pay monthly premiums and cost sharing for the prescription drugs. The premiums under Part D are also income related, meaning that higher income people pay higher premiums. People with low incomes can qualify for extra help with Part D in paying for the prescription drug costs. Plans are required to provide what's called a standard drug benefit with a deductible, you can see here, coinsurance for prescriptions up to the initial coverage limit, a gap in coverage, which is there, and this is what's referred to as also the donut hole, and it's where in the past beneficiaries had to pay 100% of their drug costs until their spending reached what is the catastrophic level. After that, beneficiaries pay 5% of their prescription drug costs. Plans can vary the design of the benefit, and in fact, most plans offer something other than the standard design, but most do have a coverage gap.
This is all making sense.
As a result of the Affordable Care Act, or what's also called the Health Reform Law, this gap is gradually closing and will be closed by 2020. In total, about 90% of people on Medicare now have drug coverage, including more than 29 million people with coverage through a Part D plan. There are also what are called other sources of credible drug coverage, which include employer-sponsored retiree health plans, the TRICARE, and the Veterans Affairs Administration. However, the latest estimates indicate that around 5 million people, or 10% of all Medicare beneficiaries, lack prescription drug coverage. So here you can see a side-by-side comparison of the cost-sharing differences under Part D in 2014 versus in 2020 when the donut hole will be closed. As you can see, when the donut hole is fully closed in 2020, plan enrollees will be required to pay 25% of the cost sharing in the donut hole, the coverage gap area, which is the same amount of cost sharing that they pay in the initial coverage period. So this is what people refer to as closing the donut hole. Prior to the Affordable Care Act, enrollees were responsible for paying all of the costs of their drugs when they were in the donut hole. Under Part D, it covers outpatient prescription drugs, and many drugs are instead covered under Medicare Part B. And it's important to understand the types of drugs that are covered under each part and the cost sharing that's associated with each, because they can be very different. Medicare Part B, as in boy, covers drugs that are typically administered by a physician or nurse as part of an office visit. Examples of these include injections and intravenous drugs. All drugs under Part B require 20% cost sharing. This cost sharing may be covered by Medigap plans, which we'll talk about more later, or other sources of supplemental coverage from a union or former employer. Part D, as in dog, only covers outpatient prescription drugs that are not covered under Part A or Part B, and excludes certain classes of drugs, such as drugs for cosmetic purposes. The coverage and coinsurance for specific drugs varies across the private drug plans. Additionally, drug plans and the drugs that they cover change each year, so it's very important to look closely at plans' coverage and reassess each year whether a plan is the best plan for a beneficiary's needs. While Medicare provides important benefits, there are significant gaps in its coverage. Unlike typical large employer plans, traditional Medicare does not limit beneficiaries' out-of-pocket costs. However, Medicare Advantage plans do have a limit on their out-of-pocket expenses. Additionally, Medicare does not cover long-term care services, dental services, hearing aids, or routine eye exams. Medicare also does not cover chiropractic services, non-medical personal aid services, concurrent palliative care, or medical expenses during foreign travel. So as you can see, there are many services that are not covered by Medicare. As a result of these gaps in benefits and cost sharing, many beneficiaries have some form of additional supplemental insurance coverage to help with unexpected out-of-pocket expenses and to provide coverage for benefits that Medicare does not cover. The largest source of this additional supplemental coverage comes from employer-sponsored retiree health benefits, which cover about a third of people on Medicare. An area of great concern is that employer-sponsored coverage for retirees has been eroding in recent years, and the cost of offering this coverage has risen. The Medicare Advantage program, while it covers basic Medicare benefits, the plans also typically cover additional services or require lower cost sharing for Medicare-covered benefits. And in this sense, Medicare Advantage plans are a source of supplemental coverage. Private insurance policies that are regulated by Medicare, known as Medigap plans, also help cover beneficiaries' cost sharing for Medicare benefits, but they can be quite expensive. And these are plans for people that are in traditional Medicare or original Medicare, not for people that are in Medicare Advantage plans. And last but by no means least, state-based Medicaid programs provide additional benefits and cost-sharing support to 10 million dual eligibles. So this leaves more than 1 in 10 beneficiaries with original Medicare and no other source of supplemental coverage. So to provide you a bit more information about Medigap supplemental policies, these policies work with the original Medicare program, as I said before, and help cover the cost sharing and deductibles for Part A and B. They do not cover the cost sharing for Part D. The structure of Medigap policies has become more uniform and regulated over the years in order to help beneficiaries more easily compare policies. Every plan of the same letter provides the exact same benefits, even if it is offered by a different company. So Plan F offered by Company 1 is exactly the same as Plan F offered by Company 2. So in this way, you can really just compare the premiums and decide what benefits you want, and it makes it much more of an apples-to-apples comparison. The majority of people with Medigap have either Plan C or Plan F, which provide the most comprehensive coverage and cover both the Part A and Part B deductibles. Beneficiaries with Medigap generally pay a monthly premium for their coverage in addition to their Medicare Part B and Part D premiums. Even though plans of the same letter, as I said before, provide exactly the same benefits, the premiums across plans, as you can see here, vary greatly. So this shows how important it is to compare the plans that are offered by different companies. People on Medicare are guaranteed an open enrollment period for Medigap with no exclusions for pre-existing conditions and no underwriting when they turn 65 and go on Medicare. At any other age or time period, for example, even when they're 66 or 67, plans can charge higher premiums based upon their age or pre-existing conditions. However, the Medigap plans are regulated at the state level with some federal oversight, and so some states prohibit underwriting for Medigap policies at all ages. Overall, as you can see here, Medicare pays for nearly half of all health care spending for beneficiaries, and people on Medicare pay for about 1/4 of their health care expenses, which is shown here in the orange. About 1/3 of these out-of-pocket expenses are cost-sharing for services covered by Medicare, including hospital services and prescription drugs. About 1/4 of beneficiaries' out-of-pocket expenses are for services not covered by Medicare, such as long-term care and dental care. And the remainder, about 42%, are for premiums, including premiums for Part A, B, D, C, and any premiums for supplemental coverage such as Medigap. In all, people on Medicare spent more than $4,700 out of pocket on average in 2010, which is the most recent data available. As you can see here, out-of-pocket expenses for healthcare grow as individuals age. Among individuals ages 85 and older, out-of-pocket expenses for healthcare are more than $8,000 on average, which you can see here at the bottom of the slide. This is more than double the average amount for individuals between the ages of 65 and 74. Additionally, the source of out-of-pocket expenses changes as individuals age. Among individuals ages 85 and older, long-term care expenses comprise almost half of their out-of-pocket expenses, while premiums comprise about 1/4 of their expenses. In contrast, for individuals between the ages of 65 and 74, long-term care expenses are only 4% of their expenses, while premiums are the largest source of their out-of-pocket expenses. As I mentioned earlier, while most people in Medicare pay about $105 per month for their Part B premium, 5% of people on Medicare with higher incomes, that is incomes above $85,000, pay more in premiums. This chart shows how much higher income people pay in Part B premiums, and the income breaks are the same for the income-related Part D premiums. The income-related premiums are structured so that higher income individuals pay a larger percentage of their Medicare costs, on average, while most individuals pay on average 25% of their Medicare Part A and Part B costs with their Part B premium. Individuals with more than $214,000 in income pay 80% of their Part A and Part B costs on average. So turning now to the Affordable Care Act and future changes to the Medicare program. As you know, the Affordable Care Act made many changes to the U.S. healthcare system, and the law also made a number of changes to the Medicare program. The law included several provisions that are projected to decrease Medicare spending by about $716 billion between 2013 and 2022. First, the law added new benefits to the program, the largest of which was the coverage gap discount program, which gradually closes the Part D donut hole. It also boosted payments for primary care services and added a new annual wellness visit for beneficiaries. It also reduced payments to many Medicare providers, including Medicare Advantage plans, hospitals, and home health providers. The law additionally created a new board called the Independent Payment Advisory Board, which has not been implemented yet, but the board would make recommendations about how to further reduce Medicare spending. It also created new revenues for the Medicare program. Specifically, it made Part D premiums income-related. It froze the income-related thresholds for Part B premiums, meaning that for the foreseeable future, near future at least, the threshold for paying income-related Part B premiums will be $85,000 in income for individuals. It also increased the Medicare payroll tax for higher income individuals. Finally, the law included several mechanisms designed to improve the quality of care for Medicare beneficiaries, including reducing payments for unnecessary hospital readmissions and reducing Medicare payments for hospital-acquired conditions, such as infections that people acquire in the hospital. So despite these reductions in Medicare spending of $716 billion, the Medicare program faces many financing challenges. Medicare spending comprises about 16% of federal spending, which puts constraints on the federal budget. The Medicare program also faces long-term financing challenges with fewer workers to support retirees and a growing number of Medicare beneficiaries. At the same time, beneficiaries incur relatively high out-of-pocket expenses, and their household budgets can't necessarily support paying higher costs. Many beneficiaries also find the Medicare program to be complex and very difficult to navigate. The Medicare program also faces challenges in providing high-quality care to beneficiaries and setting fair payments to plans and providers that care for people on Medicare. When you think about this growth in Medicare spending and future financing challenges for Medicare, part of the spending issue may be due to healthcare becoming more expensive with new technology and better treatments, but another part of the issue is due to changes in the population covered by Medicare. This chart shows how the number of people covered by the program is projected to grow over the next 30 to 40 years. The total number of seniors on Medicare is expected to grow from 45 million today to almost 80 million by 2040. Some of this growth is due to baby boomers aging onto Medicare, which you can see in the dark blue here, but it is also due to people living longer. As you can see in the chart, the number of people ages 80 and older, which are shown here in the yellow and orange, is projected to greatly increase over the next few decades. So much of the increase in projected Medicare spending over the next few decades is due to changes in the Medicare population, which leaves us with the dilemma of how to pay for the additional spending. So if Medicare is already a sizable share of the federal budget and beneficiaries pay a sizable amount in Medicare cost sharing, how do you then reform the program? Many policymakers have proposed changes to Medicare, and here in no particular order are the most frequent proposals for reforming the Medicare program. Many have proposed increasing the Medicare Part B premium for all beneficiaries or further means testing the program and requiring the wealthy to pay more. Policymakers have also proposed raising the age of Medicare eligibility, but this actually would not save as much money as people think. Some proposals would change Medicare from a program with a defined set of benefits to a defined contribution program, in which the government would give Medicare beneficiaries a fixed amount of money to purchase a health insurance plan in the private market. Others have proposed restructuring Medicare's cost sharing with combined deductibles, new coinsurance, and an out-of-pocket limit. So in short, there is a variety of proposals to reform the Medicare program and reduce the projected Medicare spending in the foreseeable future. But shifting costs from the federal government to beneficiaries would generally not solve the problem, and there's a delicate balancing act between keeping medical care accessible and affordable for beneficiaries, setting fair payments for plans and providers, and financing the program for future generations.
Do you have any questions?
So for more information, these are some of the resources you can turn to on our website.
We have received numerous questions through the computer, so I will be asking those to you first, and then we will go to the phone for some additional questions. So, Dr. Jacobson, the first question we have, during the October-November enrollment period, is there ever a restriction in changing from Part A, B, or D to Medicare Advantage?
No, that's exactly when, if people are going to make that switch, that's the only time during the year when you can make that switch. And that is what that period is designed for, as well as to switch among Medicare Advantage plans or among standalone prescription drug plans.
Ever look at your zip?
No.
Great. Thank you. The next question, let's see. As far as reporting income, if the patient does not report their income to Part B, is it automatically determined from the IRS filing? And if so, do they separate the Medicare patient's income from the joint filing statement?
The income-related premiums are based off of tax filings. So that is where the IRS gets the information, where the Social Security Administration gets the information from the IRS. One important thing to know about the income-related, a couple important things to know about the income-related premiums is that because it's based upon the tax filings, there's actually a 2-year delay between when your income may change and when it is actually affected by the income-related premiums. So to make this more concrete, let's say someone retires in 2014, and so their income goes down for half of 2014. They will then pay income-related premiums for 2015 because that will be based upon their 2013 tax filings, and they may also pay income-related premiums for 2016. If someone's income goes down, they can appeal to the Social Security Administration and provide proof that their income has gone down and that they should not be paying income-related premiums. And that was probably more of an answer than you wanted, but that's the complete answer of how the income-related premiums work.
That was excellent. Our next question, should patients at all be concerned about the reduction of payments to hospitals and doctors and restricting the acceptance of Medicare patients versus non-Medicare patients?
So the data that we have looked at actually shows that most doctors around the country accept Medicare patients. We occasionally hear anecdotes about physicians not accepting patients, but this actually doesn't show up in the actual data when physicians are asked if they take Medicare patients.
Okay, and this sort of, I think, dovetails onto that. Can hospitals refuse Medicare patients?
That's it's not an issue that has arisen in any time recently, because all hospitals take Medicare and are paid by Medicare. And actually, even if you're in a Medicare Advantage plan, you can go to a hospital that's out of network, even if the hospital is not within the network of the Medicare Advantage plan. You may have to pay higher cost sharing, but hospitals take Medicare patients.
Thank you. The next question, I think, actually, Dr. Jacobson, we had spoken about this prior to today, and I don't know if you've had a chance to actually look at it, but I know that there's been concern from our patient population about the coverage of auto and allo stem cell transplants under Medicare, and I know the IMF has been in touch with CMS, and we've never seemed to get a concrete, clear answer about the coverage, and I don't know if you had time to look into it before today or not. If not, we can certainly follow up with everyone, after the presentation. But we did receive that question, and I wanted to ask.
No, I think that is probably a better question to follow up with CMS about to get a concrete answer.
Okay, we will definitely do that. Actually, if Jen or Joanna on the line, if you wouldn't mind at least telling folks the one answer that we received when we touched base with CMS about the allo and auto transplant coverage. All right, well, we'll come back to that question. Dr. Jacobson, the next question is, when will Medicare regulate the administrators of nonprofit hospitals for very high wages for administrators and overhead? I'm not sure that that's a question you can answer, but
yeah, it's an interesting question, but it's really not something I can answer.
Okay, we can follow up with that person offline. The next question, and again, I'm not sure if you can answer this, but feel free to offer any insight you may have into it. The question is, as we all know, the anti-cancer medications that fall under Part D for myeloma patients are typically placed on a very high specialty tier, which results in high cost sharing, and it's extremely expensive. And so they're just asking if you foresee any change to that. I can tell everyone that we are working on, the IMF is supporting legislation that has been introduced regarding Part D Appeals Act, and so it allows patients to appeal the decision to have your Revlimid or your other oral anti-cancer medications on here, and we have an action alert on our action center at advocacy.myeloma.org that you can go to and send an email to your member of Congress asking them to please support the legislation. So it is something that we are working on.
You get it paid for. Yeah, anybody.
We're receiving a lot of feedback again. So if we could go back to the stem cell transplant coverage question. I don't know if Joanna's been able to unmute their lines to answer the.
Hi, Megan. Can you hear me?
Yeah.
Okay. Okay.
Did you say yes to me, Joanna?
I can hear you.
Great. Hi, everyone. My name is Joanna Gray, and I'm one of IMF's federal advocates in Washington, and I'm happy to answer at least our understanding of Medicare coverage for transplants. And sorry for the delay. I wasn't able to get my phone unmuted. So our understanding is that Medicare covers a single, I'm going to mispronounce this, auto stem cell transplant for Medicare beneficiaries. So there'll only be one transplant covered as long as you are on Medicare. Sometimes people ask if Medicare will cover a single auto transplant if the patient has previously had a transplant covered by private insurance. And the experts we've spoken with have said that Medicare typically does cover another transplant, but they will only cover one auto transplant while you're on, you or your family member is on Medicare. Allo transplants are not covered as treatment for multiple myeloma now, nor is tandem auto stem cell transplants. Those two types of transplants are not currently covered for Medicare beneficiaries, but one auto transplant is covered. So I hope that helps.
Thank you, Joanna.
Use of those allo
transplants.
Again, if you're not asking a question, if you could mute your line on your phone by pressing star, that would be really very helpful. At this, I would like up to questions for people on the phone. To unmute your line, you press, I believe, pound. But if you're not asking a question, please remain muted because we're really receiving a lot of feedback from people's lines. So if there's anyone on the phone that does have a question, please unmute your line by pressing.
Yes, I do. Under what circumstances would a person who is approaching the age of 65 and who's covered under his wife's insurance plan, which is very good, delay getting Medicare?
Sometimes.
Yes, I'll answer this question. The overlap in coordination, just to say this, between employer-sponsored coverage and Medicare it's complicated, and it depends upon, of course, what the benefits are and how much one is paying for the employer-sponsored coverage. Generally, it makes sense to, very broadly speaking, to stay on the employer-sponsored coverage and delay enrollment in Medicare. Some employers, depending upon how their plan is structured, and depending upon whether it's the spouse or the primary person on the employer plan, the employer will provide some sort of retiree benefits that will wrap around Medicare and help cover Medicare cost sharing. But if it's a large employer plan, then actually this is where it gets complicated, but the employer would pay first and Medicare would pay second if someone goes on to Medicare. So this is an area where there's actually really not a straightforward answer, but generally it makes more financial sense to stay on the employer plan. But you want to look at the details.
I appreciate your time. If I do decide not to go on to Medicare when I turn 65, do I need to go down to declare that, or do I just not declare it?
I believe you need to declare it with the Social Security Administration, but that's something that you'd want to check with them, that you have another source of credible coverage is essentially what you would be telling them, so that when you go on to Medicare, whenever that happens, you don't pay the you don't pay not the income related, but you don't pay the additional premium penalty that you pay if you delay going on to Medicare and don't have a source of credible coverage previously. So
okay.
So let's say, for example, you delay going on to Medicare until you're 67, but you don't have coverage between 65 and 67, you will pay an additional penalty on your premiums for the remainder of your years on Medicare.
Okay. All right. That makes sense.
I hope that was
Thank
helpful.
you very much. It was very helpful, and I appreciate your time. Thank you.
Thank you, Dr. Jacobson. Are there any additional questions on the phone? If you have a question, please unmute your line by pressing #6. Also, if you are joining us via your computer, we're still taking questions in the Q&A box, so feel free to type in a question there. Hi, did somebody have a question?
Megan, this is Joanna. I just saw another question in the chat box that I thought I would throw out if no one else has a question. Dr. Jacobson, you had indicated that high-income beneficiaries, I think it's over $250,000 of income, have to pay 80% of the cost. I think it was 80% of the cost of any services they get. And we just had a question wanting to confirm that that was true, and what about the cases of very expensive procedures? Do folks have to pay 80%?
I'm glad you asked that question to help clarify that. It's 80% of the average cost of beneficiaries. So most beneficiaries pay 25% of what Medicare covers, 25% of Medicare of spending, and that's Part B premiums. However, for people who make more than $214,000, they pay 80% of the average Medicare costs. And 80% of the average in 2014 is $336 per month. So everyone who makes more than $214,000 pays $336 per month, regardless of their actual Medicare costs or spending. Does that make more sense?
So it's not that you pay 80% of the cost of your services. It's just that you're guaranteed to pay the higher premium cost.
You're paying, right, which is equivalent. That $336 per month that the highest income people pay is 80% of the average of cost for the average Medicare beneficiary. Of Medicare costs for the average Medicare beneficiary.
But you still only pay 20% of any particular service that you get.
Yes, it's only the premium that's affected, not the cost sharing for specific services. And again, everyone of the same income pays the same premium, regardless of their actual Medicare spending.
Gotcha. Okay, thank you. Yes, I think that answers the question.
Yeah, I'm glad you asked because it's a confusing area.
We just received another question regarding premiums, and they're asking if they inherit money, if that figures into the premiums. I assume they mean, is that counted as income?
Right. If it's only assets, if it's in their savings account and it's not income, then it wouldn't count annually as part of their premiums. However, if it's recorded as income the year that they inherit the money, then yes, and 2 years later, they would pay an income-related premium unless they filed an appeal with the Social Security Administration or CMS.
Thank you. We just received another question. I don't know if you'll have the answer or if it's something that we'll need to follow up with them offline. I know that a lot of the folks on the phone have very specific coverage questions regarding what's covered under your specific plan for myeloma, and we're happy to answer. And those questions are help you navigate to answer those questions. You can always send an email to advocacy@myeloma.org, and we'd be happy to assist you. For a person who is experiencing active cancer treatment, so they are on some form of chemotherapy or anti-cancer medications, what is the best way to evaluate whether a Medicare Advantage or a Medigap policy is a better financial fit?
So there's actually, unfortunately, a lot of components to think about here. So one thing to remember with Medicare Advantage plans is that they have a more restricted provider network. So people won't be able to pick and choose any physician or any hospital to go to for their cancer care. So if they're going to go into a Medicare Advantage plan, they should take a very close look at what providers are included in that plan's network. So that's one important non-financial consideration. But when they're balancing the two, so Medigap plans cover the cost sharing for Part A and Part B services, such as chemotherapy. So depending upon what the age is of the beneficiary and actually where the beneficiary lives, since the rules around Medigap policies vary across states, Medigap policies could make more sense in a Medicare Advantage plan. It depends, because Medicare Advantage plans will have lower premiums, but they may have higher cost sharing for those services. And to be more concrete about the variation in Medigap policies, in some states, they require what's referred to as community rating, meaning that everyone who has a Medigap policy offered by the same insurer pays the exact same premium regardless of their age, regardless of their health status. But not all states require that, and some states have different required ratings. So it's really important to look at what the rules are in the states and what your premium would be for a Medigap policy, as well as what your potential cost sharing would be under a specific Medicare Advantage plan. I hope that helps answer that question. Choosing amongst plans can be very complicated.
Yes, thank you.
But they have advocates, right?
Dr. Jacobson, I guess, is there a good reason that people or myeloma patients could seek out to help sort of navigate those types of questions? Contact directly with CMS, or is there another resource that they could go to for specific?
One resource that people may want to look at is every state has what's called a state health insurance program, or it's also called a SHIP, and they have different names in different states, but they are all federally funded resources at each state, and they are designed to help people navigate among the different private plan options and help them to figure out what financially would make the most sense for them. So I would look at the state health insurance programs within whatever state the person is in. All the states as well also typically provide guides for Medigap policies so that people can easily compare the premiums for the same plan across different companies. But a lot of those guides are only provided for 65-year-olds. But it at least gives you a starting point.
Thank you. That's very helpful.
And I should also add that that using the state health insurance programs is also a free resource for people, so they won't have to pay to use it.
Great. Thank you so much. It is 8 o'clock East Coast here. We have reached the conclusion of our presentation. I will ask one more time if there's any additional questions. We're happy to answer them. You can type them into the Q&A box, or you can unmute your line by pressing pound 6 to ask a question. If not, these This presentation has been recorded. It will be posted on the IMF website. We will notify all participants when it has been posted, as well as those that were unable to make it tonight. We will let everybody know once it's posted through our weekly Myeloma Minute, our weekly e-newsletter. And I want to thank Dr. Jacobson again for taking the time to speak with us tonight. Excellent presentation. Great job answering questions. And if anybody has questions after tonight's presentation, again, please send an email to advocacy@myeloma.org. We'll be happy to help you. So thank you, everyone, for joining us.
Thank you. It was a pleasure to speak with everyone.